everyone. Good evening. Hope you are all doing well. So my name is Darwin Chimba. I'm the Director of Operations for the Association of East African Neurosurgeons, and I'm a fifth year medical student at Copperbelt University in Zambia. So I welcome you all to this inaugural presentation for the Neuro Oncology Course. We've been looking forward to this course, and I'm very glad to see this turnout. A lot of people coming in and having this panel. So thank you so much, everyone, for coming. And we're going to go straight into introducing ourselves. So I'm going to be calling on the names as they're appearing on my list so that we can introduce ourselves. Then the presenter is going to introduce himself and begin the presentation. And before I mention that, this is quite an interactive session, and I'm very glad to see senior colleagues joining us because obviously we're going to get quite some good guidance on the topic of presentation. So I'm going to start with Dr. Kabulo. You can please introduce yourself.
Hello, everyone. I'm Kabulo, neurosurgeon in Lubumbashi, Democratic Republic of Congo. Nice to meet you all.
Thank you so much, Dr. Kabulo, for being here. We really appreciate it. Then we have Dr. Daniel Safari.
Hello, everyone. Good evening. I'm Daniel Safari from Democratic Republic of Congo. I'm a junior medical doctor.
Thank you so much, Dr. Daniel. Again, I've got, then we also have Michael.
Hi, everyone. My name is Michael Bamimore. I'm happy to be here today. I feel like this is going to be a good lecture. So thank you. I'm a fourth year medical student at Philadelphia College of Osteopathic Medicine. Sorry.
Thank you so much, Michael. Then we have Olalua Ezekiel.
Good evening, everyone. I am Olalua Ezekiel Dada. I'm a second year medical student from the University of Ibadan, Nigeria. Glad to be here. Thank you.
Thank you so much, Ezekiel. Then we have Tunde. Hello, Tunde. Please introduce yourself.
Hello, everyone. I'm Olopatoki Tunde. I'm a fourth year medical student at the University of Lagos here in Nigeria. I'm really happy to be here. Thank you.
Thank you so much, Tunde. Then we have Dr. Franklin.
Hello, everyone. Nice to meet you. I'm Dr. Titino Franklin, a medical doctor from Cameroon and research fellow at the Association of Future African Neurosurgeons. Thank you, and nice to meet you.
Thank you, Dr. Franklin. Then we have Juanita.
Hello, everyone. My name is Dr. Juanita Najuma from Mombasa. I'm a senior medical officer. Nice to meet you all.
Thank you so much, Dr. Juanita. Then we have Dr. Esen Daniel. Please go ahead.
I'm Daniel. Daniel from Bukavu in the Democratic Republic of Congo. It is a big pleasure to be a part of this session today. Thank you.
Thank you so much, Dr. Daniel. Then we have Alice.
Hello, everyone. I'm Mutoni Alice, medical student level 3 from University of Rwanda in Rwanda. Thank you.
Okay, thank you so much, Alice. Then we have Dr. Chibuikem.
Good evening, everyone. My name is Chibuikem Kugweng, medical doctor from Lagos, Nigeria. Thank you.
Thank you so much, Dr. Chibuikem. Then we have Musakanya.
Hello, everyone. My name is Musakanya Shituluka from the Copperbelt University School of Medicine, and I'm glad to be here.
Thank you so much, Musakanya. Wapres. So you're kind of low, Wapres. You can just try to be a bit louder. Okay, I don't know if I'm the only one who can't share that. Maybe you can just type in the message box and send your introduction there. Okay, then we have Chidiye Bere.
Hello, good evening, everyone. It's nice to be here today.
Thank you so much. Then we have Dr. Oric. So he's in a place where there's quite some background noise. So we have Dr. Oric with us. He's the founding president for the Association of Future African Neurosurgeons. So then I'm going to call upon the today's presenter, the first presenter for our Neuro Oncology course. He's going to introduce himself and begin the presentation. Ahmed, you can go ahead.
Okay, until this problem is solved. Hello, everyone. It's my pleasure to be here and pleasure to be with this evening with you. I guess it's evening here in Egypt. It's around 8 o'clock p.m. So good evening and good morning for those who are having it in the mornings. My name is Ahmed Khaled Awad. I'm a first year medical student at Ain Shams University, Egypt. And it's my pleasure to be starting the first presentation for this Neuro Oncology course. And it's somehow like threatening, or I'm so much, I have so much anxiety now, but I will try to control it and start the presentation. I have a lot, the participants are a lot of neurosurgeons and my dear colleagues. So I hope it will be a beneficial and good presentation. I'll try now to share the screen. Yes, I can share it now. Okay. Share now. Oops. I guess now you can see it, right?
Yes, perfectly.
Okay. So let's start. This is the first session of the Neuro Oncology course presented to you by the Association of Future African Neurosurgeon. I hope that all of us will be, my dear colleagues, for sure, will be the future African neurosurgeons. And I wish a great future for those actually pursued this dream. It's my dream. So those doctors who actually pursued it. So to be leading us for pursuing our dream too. It's presented to you by me, as I mentioned before, and this is my email. If anything, if anyone want another information or like a follow-up papers, if you want to read it or anything. So let's start with our first case. So let's. I will be talking like to my dear colleagues, our mentors and our neurosurgeon will be something like a pleasure to have you here. So I'll start with talking like I'm talking to my friends. So for my friends, let's imagine you are now a resident doctor or yes, a resident doctor or a resident neurosurgeon in your hospital, and then the following case is coming to you. 40-year-old, otherwise healthy female presented to you with the 6 years of forcing headaches and 2 years of memory problems. She had a 2-minute episode of sudden onset of weakness of both legs without loss of consciousness. Past medical history showed that she has past urinary tract infection. Otherwise, she was completely healthy. So upon examination, she was awake, alert, and have intact speech. Cranial nerves examination and visual field were intact also. She had like a left pronator drift, mild left pronator drift, and gait were balanced, and there were like a mild numbness in both left arm and left leg. So for you, what will your differential diagnosis be like? So what do you think like this case is, or what differential diagnosis you're going to put to this case if it presented to you? So please, if you may, open your mic and start discussing the different diagnoses if you have any on your mind. Do you hear me? If you have like a 16 participant, I want to hear one differential diagnosis. I have even a small hint. Yes, hello, how are you?
Oh, great. It could be idiopathic intracranial hypertension. That's one sort of differential, I think.
Okay, great. If anyone else has another differential diagnosis?
Yeah, I'm thinking at this point it could be a space occupying mass because of her sudden onset weakness, the headaches that she's been complaining of, and also, the pronator drift.
Yes, so. Great. Great. If anyone has any others, why not of not thinking like an if you have this case present us with headache, so one of our doctors put a differential diagnosis of forcing headaches of a mass in intracranial. So didn't you think didn't you think of like a vascular problem, and what can be like a vascular problem, what it can be, if anyone thought of a vascular problem?
I think if it was a vascular problem, it could be like a anterior circulation problem, like an ACA, mostly because of the weaknesses in the legs.
In the leg, yeah.
Most likely on the right side.
Great. So, anyone have anything else?
And another thing you could, because of the chronic nature of the memory problems, you could maybe need to exclude a vascular dementia type of thing. I think that's just sort of going out there. Just one of the, yeah.
Yes, excellent, yes. Okay, so let's say we have put in our mind the differential diagnosis of, okay. Like our doctor said, we can propose that like a neoplastic, if primary or metastatic tumor. We can go for vascular, so anterior, like anterior vascular malformation, cavernous malformation, organ aneurysm with mass effect, stroke, and complex migraine. Also, we didn't think of another side, like we have to put in our mind when we examine the proposal of there might be an infection. So in our differential diagnosis, infection also take a place, and infection like brain abscess. Infection also like brain abscess or meningitis take a place in our differential diagnosis. It may be in our history, we can ask her about if she had like a trauma or like an accident that happened to her. And from her past history, she wasn't having any chronic disease like diabetes or hypertension or anything. So we can put the multiple metabolic cause in the differential diagnosis, but due to her past healthy without any chronic disease, we go for the neoplastic and the vascular differential diagnosis as mainly. So what do you think now is the next step we should take for such a case? 84 with multiple headaches, and we are thinking about neoplastic or vascular disease. What are our next step? I think I gave an hint by falsely skipping the slides. If anyone could share with us what will be the next your next step.
Okay. I think. Hello.
Yes, hello.
I hear you.
Yeah.
Darwin, can I say something?
Sure.
Okay, Ahmed, before we go to the next step, I like the way you put the differential diagnosis. So now I want to ask you, from those ones, let us make aside the classification of neoplastic, vascular, infectious. If I ask you to choose the most probable diagnosis, 3 of them on that list, which one will you start with? You get my question?
Yeah.
I'm saying you make a good classification. It was systematic: neoplastic, vascular, infectious, trauma, metabolic. But now I just want to ask you, from that list, if I ask you to choose 3 differential diagnoses, which one will you start with?
I guess due to the numbness in the legs and so on, so I would go for like there is a mass pressing on the brain, so I go for neoplastic as the first choice, and then afterwards I go for vascular.
Okay, okay. Neoplastic, will you start with metastatic tumor?
Probably, if she like presented with if you are talking about our case,
yeah, we are talking about our case. Yes.
Yeah, I will not go for metastatic, but if she showed like a prior cancer or a prior like a breast cancer, we know that breast cancer is highly metastatic.
That's not the first reason. which one is the first reason why you are not going for metastasis? It's because of the period, the symptoms.
Yeah.
The patient presented with 6 years.
Yes.
Okay, it was like headache over 6 years. So you won't start with metastasis. You will start with primary tumor. Then which one are you going to take the second here from the list?
I will go for
choose
vascular.
either from infection, from trauma, for what? Sorry?
Vascular.
Which one?
Anterior-vascular malformation.
Yeah, like which one?
Vascular, like the giant aneurysm, maybe.
Okay. But you see, aneurysm, for it to give the symptoms you have in your patient, it has to be very big. Yeah, which are also rare to get those giant aneurysms. So it can be an AVM, it can be a cavernous malformation.
Yes.
We won't also go further to infection because of the history. Infection, brain abscess can't give you 6 years history. So like if we say, let us choose 3 from this list, the most probable diagnosis is primary tumor. The second, then we can choose either cavernous sinus followed by AVM.
Okay. And then brain abscess.
Brain abscess will be the last one. Metastasis, the last one, because of the duration of the symptoms. You get my point?
Yeah, I got it.
Yeah, it's okay. We can carry on now.
Dr. Kabulo, there's a question by Lorraine about why the brain metastasis will not be presenting in 6 years.
Okay, thank you so much. Brain metastasis, you get a very small lesion with a huge, very huge perilesional edema, which won't wait for the 6 years to give you symptoms. It will give you symptoms in less than 6 months or less than a year, you get symptoms. And also brain metastasis, even without mass effect, it will start with seizures. You get seizures in less than 3 months, you get already seizures because it will be located at the junction between white and gray matter.
Thank you, Dr. Kabulo. If I can add to the pathophysiology, Lorraine, remember that, I'm so sorry for the background noise. Remember that the metastasis have this particularity that for them to go to see to another region, they need to acquire certain peculiarities. They need to be able to go to the region without having adhesion, having a lot of vascularity, and being able to grow rapidly, right? So that's the reason why when you're thinking about something that is malignant, there's that tendency for it to present rapidly in a very short period. Very important. So those are the elements that orient you towards that. And then there's also the characteristic that metastasis usually have more than one lesion. So you would expect usually to have, if you have focal symptoms, you will not just have in one site, you would have others as well. So those are all elements. It doesn't mean it's always the case, but those are elements that orient you.
Right. I guess, Ahmed, you can go ahead.
Okay. Thank you for the input, doctor. And then my question was like, if we have like now we bought 3 differential diagnoses: the primary tumor, vascular, and infectious. What would be the next step I should carry on, or you should carry on in this case? If anyone have an
I believe we can do some imaging to help rule out or rule in certain things.
Great. So this is the point of differential diagnosis. We put like a many diagnoses, and we start eliminating or excluding one by one. So the most concern for me and for everyone should be the primary tumor of the brain. So I have to do, like, the first step I have to do is like a brain imaging, CT or MRI. So that's what we have done, and then that will happen. That will appear. So if anyone can ask or can contribute, what do you see here? Like the first A, B, or C image? Any description or any like explanation for us? What you might think that's either this? Hello.
Anyone ready to contribute?
I can give it a try.
Yeah. Okay.
So in the first image, the A image, we have a CT scan that is non-contrasted axial CT cut. I think it's most likely infraventricular, and we see a mass almost like in the middle, the
Yes.
superciliary cistern, with surrounding edema on the right side. That's going towards the frontal region of the brain and also the temporal regions. I don't see any ventricular collapse or other things that are prominent there. And then on the B, I think the B and C are T1 MRI with contrast that is showing homogeneous mass, which seems to be in the frontal floor, skull base of the skull that is compressing posteriorly into the midbrain a little bit. Yeah, I don't really see any other demo or any restriction. I don't know what other MRI sequences we have, but so far that's what I can tell. So
I think that's a good description. Would you? How about you describe the relationship between the tumor and surrounding bone structure?
yeah, so on the CT, the tumor is actually hypodense to the bone. So the bone is very hyperdense. The tumor is actually hypodense. Also to the, it's a little bit isodense to the brain, and also I see some mild calcifications, a little bit of hyperintensities within the tumor itself. On the MRI, it's definitely hyperintense to the brain, but homogeneous and well circumscribed. So.
Yes.
Well done, Nico. Then can you answer out the question asked by Dr. Ilri? Demarcation between the tumor and the brain tissue.
The difference between the tumor and the brain tissue?
Yes.
Yeah, I said the brain, the tumor.
It's well demarcated. So it's well circumscribed tumor. Okay?
Correct.
And you mentioned it's homogeneous. It's a very solid tumor.
Yes.
And what do you think? Is it an extra or intraaxial tumor?
Oh, I see what you're saying. It's an intraaxial tumor. Actually, extraaxial tumor, actually.
It's extraaxial tumor.
Yeah, extraaxial. Yeah.
Yes. Then here, usually when you are talking about density, let's compare it to the brain tissue, the brain parenchyma, not the bone. So here, the first image, the image A, the tumor is isodense. Okay?
Yes.
Yes, and well done. You mentioned calcification. You only mention calcification on pre-contrast. You don't mention calcification on post-contrast image. Only on MRI you can do that, but on CT scan, it's only on pre-contrast because you might confuse contrast with calcification. Then check very well on image B. There's something very interesting which you have to mention when you're talking about this tumor on that image.
Is it the tail that kind of
yes,
goes
there is
lateral?
a tail.
Yeah.
There's a tail.
Awesome, man.
Yes. That's an important feature to mention there.
Yeah.
Okay. Yes.
Thank you,
and
sir.
Also check now the image C.
Mm-hmm.
There's something you have to mention there.
It's sort of like affecting the optic nerve or like invading the optic nerve.
Of course, already from the image B, you can see that the tumor is invading the lateral wall of cavernous sinus on the right side, which probably maybe is encasing the carotid artery. But check now properly on the image C.
Like invading intracranial, like this, the tail getting upward.
Vascularity. Can you see vessels?
Yeah, there's a vessel superiorly to the tumor.
Yes, and anteriorly to the tumor. There are vessels there.
Yeah.
Thank you.
So great here. There are a few questions that have come in. First of all, Gideon asked about extraaxial versus intraaxial. I think we should take some time to explain that. And it will also be nice to talk about surrounding structures so that everybody can learn what these structures are. So please, Ahmed,
help by pointing out the dural tail and pointing out the optic nerve, the cavernous sinus, as well as if you have any difficulty, we will help you with that so that everybody follows.
Okay, like you now see my arrow, my pointing.
Yes, yes, yes.
Yes, yes. As our doctor said in the first image A, that up there, and the calcification is starting here. And as our doctor said, the calcification is better to be commented upon pre-contrast in the CT. And there is like the areas of hypodens here is like the edema. Properly, yes. The other side, picture B, the tumor is well circumscribed. We are comparing the tumor to the brain parenchyma itself, so it well circumscribed, and it has like the small tail extending on the sphenoid wing, and it like invading the lateral wall of the sphenoid. On picture C, we like seeing the vascularity. The vascularity is above here, the extent of the tumor through the vascular vessels, sorry, and here also. And this is what we have saying in this. Oh.
Ahmed, go back to the image A, sorry.
Okay, sorry. Yes, image A, yes.
To A, yes. Then yes, just below there, you see the pons. Can you see the pons?
Yes.
The pons.
Yes.
No. That's the petrous part. Okay. Go to your right. No, inside. Go inside. Can you see the fourth ventricle?
Yes.
Go back now. Yes, that's the fourth ventricle. Okay. No. Inside. Yes, that's the fourth ventricle.
Yes.
Then go up. That's the pons. For you to know that is the pons, where the arrow is, that dot is the basilar artery. Just remove a little bit the arrow. Remove the arrow. Okay, can you see that dot? That's the basilar artery. Yes, which is showing you that that is the pons. Remember, the basilar artery is just running in front of the pons. Vertebral arteries unite at the pontomedullary junction to form the basilar artery. At the junction between pons and midbrain, it's separate to give you the end arteries, the posterior cerebral arteries. So if you check very well, there is also on the right side compression of the pons. The tumor is just getting into the prepontine system, compressing the pons. Can you see that? Go to your right, the right side of the patient, right side of the patient, right side of, no, that's the left. Right side of the patient, it's your left.
Yeah.
Yes, now go to the pons, just lateral to the basilar artery. Yes, you see, the tumor is even getting into the prepontine system, compressing the pons at that level. You see, yeah?
Yeah.
Yeah, thank you.
Okay. Like we have said, and non-contrast or pre-contrast CT in figure 8, it shows like isodense, like in the same density between the tumor and the brain parenchyma. They are on the same dense, so it's like isodense mass along the medial portion of the lesser wing of sphenoid, and this appear more in the MRI, the picture B, like we said, in the sphenoid wing. Have like the sphenoid wing and over here, that's all the sphenoid wing, so the medial side of the sphenoid wing. And on differential diagnosis of us would go for sphenoid wing meningioma, or it can be like another atypical or malignant meningioma or granuloma, or like a metastasis. But as we have mentioned before, metastasis in this case, a 6 year presentation of headache, so we're gonna exclude metastasis. So what other labs or work you can do after you have to do after seeing these images? Anyone have any?
Thank you, Ahmed.
I have a question.
Before we move on, let me just clarify something there. Calcification appears white on pre-contrast CT, but on MRI, calcification is dark. So it's hypo-intense. It will appear like flavoid. in both sequences. T1 and T2 calcification is dark on MRI. But on CT scan, pre-contrast calcification is white. I wanted just to give you that precision. Darwin, you can carry on.
Yes, I have a question. Maybe I'll direct it to you, Dr. Kabulo. I'm aware that, how can we differentiate between, let's say, like when you look at the vasculature on image C, when you look at the vasculature that is posterior to the tumor and anterior to the tumor, how would you differentiate between vessels that are arising primarily from the tumor and those that are just engulfed by the tumor?
Okay, usually on this, it's very difficult. You have to check with the angiography. But usually what is there? You see like that small artery on top of the tumor, it's big from the tumor and getting small where it is going into the brain parenchyma. It looks like it's coming from the tumor going the other way. But when it is going into the tumor, it starts big and getting small towards the tumor. You get it, like always vessels into the brain, they are big. The more they are going to the cortex, they become small. That's just a fact, but it's not very clear to know that this is from the tumor, this is going there. But with the angio, you can, or DSA, you can see them very well.
Okay, thank you so much, Dr. Kabulo.
You're welcome.
I don't know if we actually answer the question about extra-axial versus intra-axial. Okay.
Okay, extra-axial, it's the tumor which is coming axial. It's extra. It's not inside the brain parenchyma. It's the tumor which is coming from meninges, now pushing the brain, getting into the brain. Intra-axial is the tumor like a glioma, which is starting inside the brain parenchyma. You have to see the epicenter of the tumor. If the epicenter is inside, that's an intra-axial. If it's outside, it's an extra-axial. Extra-axial means it is starting from either the bone or meninges, pushing the brain, getting into the brain. Like this tumor, you can see it's a dural-based tumor. It's starting from the base, it's outside, from the meninges getting inside. I don't know if it's clear.
Ahmed, point the base, please. On the, it's really clear on the second
on image
one.
B. Go on image B. Yes, point the base. Yes, that's the base of the tumor. And it's now growing into the brain parenchyma. Yeah. And extra-axial, you will see that the epicenter is within the brain parenchyma, now going just a small part, maybe touching the meninges.
Thank you so much, Dr. Kabulo. So for the students, you really need to structure in your mind, right? Have the category, have the compartments. You have, when you think about the meninges give you spaces, right? You have 3 meninges, remember, from outside to inside. You have the dura, you have the arachnoid, you have the pia mater. Now, pia mater is intimately linked to the brain, so or the spinal cord. So you equally hear these terms in the spinal cord as well: extra-axial, intra-axial. So when you think intra-axial, you're thinking about brain parenchyma. So you're thinking pia mater and brain parenchyma. When you say extra-axial, like Dr. Kabulo said perfectly, you're thinking something that is outside of this axis, which is the center, which is the brain parenchyma or spine parenchyma. So, for example, this tumor we're seeing here. So keep that in mind. And that's why you need to know the epicenter, study the tumor, try and see if you can see where it's dating from.
Okay, thank you. And then we can, what are the next investigation or the next steps you have to take in after seeing this tumor? Still yet undecided. We have put in mind, but we have structured our mind to like it's a tumor. It's not a vascular, it's not infection. We structured our mind into the brain tumors. So we are talking about either meningioma or either granuloma, or also a solitary fibrous tumor. So afterwards, what are the next step? The next step will be like in doing a further workup for the lab We have to do like a routine labs. We have to do like a serum reactive protein to exclude if it's what is infection or not, and we have to do like an imaging. Our doctors have just answered the question of our colleagues, like is saying if it was a vascular tumor growing on from a vascular structure or it is compressing the vascular structure. We have to do here the cerebral angiogram. The cerebral angiogram should specifically be done in the case of large meningioma that may be vascular and benefit from preoperative and this we are going to think about doing a cerebral angiogram if there was a preoperative or if there was like an embolization. So specifically for sphenoid wing meningiomas, they drive their vascular supply, or meningiomas drive their vascular supply from the middle meningeal artery or the internal carotid. And specifically for sphenoid wing meningiomas, they are driving their blood supply from the sphenoid branch of the middle meningeal artery. So we have to think about cerebral meningioma. We have also to think about or start doing CT for chest, abdomen, or pelvis in a suspicion of metastasis. So to see if the meningiomas or the tumors send metastasis if there are other masses in other areas. We have also to consult the neurointerventional radiologies to start doing the cerebral angiogram. And ophthalmology too. We have seen in our last pictures, especially specifically picture C, that it may be invading the optic nerve. So we have to consult the ophthalmology to start investigating the optic nerve, and if it involves the cavernous sinus, it may be the tumor can here maybe lead to blindness or diplopia. So. For you.
Sorry, Ahmed, can we go back?
Okay.
Please. Okay, thank you so much for laboratory workup. Of course, what you mentioned, for me, I will add hormonal workup because the tumor is now invading the cellular region. Okay, you can get stalk effect. Okay, I will add also that. And for imaging, when we are doing chest, abdomen, pelvis, it's called TAP scan. TAP scan, usually you see in the books, TAP scan, TAP, thoracic, abdomen, and pelvis scan. It's not to check if the meningioma is whatever, invaded those structures or abdomen, thoracic, no. It's to check if that is a metastasis, then we are looking for primary into the chest, abdomen, or pelvis. You get it? Not the other way around. We are doing the TAP scan to look for primary when we are still looking for differentials. Is that a metastasis? If it is, then can we look for primary into the chest, abdomen, and pelvis? And yes, why are you calling neurointerventional radiologist for now for this tumor?
For the cerebral angiogram.
Sorry?
For the cerebral angiogram?
No, not for the cerebral angiogram. Not for the cerebral angiogram. You're calling the neurointerventionalist for embolization, for possible
embolization of the tumor. Yes, thank you, Dr. Hillary. And another thing, maybe we'll mention that later on. Another thing, what is the appearance of that tumor on your image D?
Here, like it have a sunburst pattern.
Sunburst, thank you so much. You see like blushing.
Yes.
Okay, thank you.
Please go back to it and show the sunburst pattern so that the others understand.
Go back. The sunburst image is here, like this.
Yes. Point to the sunburst. So sunburst for all the others, you need to know what it is like. I think we've all seen these astronomical images of the sun, right? And then there's some moments like the sun acts like it has lava and it throws away some of that stuff. So can you show that place that is bursting out of what would be the sun? The sun is the darker part, and the burst is the less dark part at the top, like northeast, up, northeast. No, up. The burst is what's coming outside. Up, go up again, go up.
Top of the tumor. Top of the tumor. Yes.
Go
again.
Yes.
You see now what is happening up there. Go again a little
It's
bit
like a
up. You
burst.
see what is happening? Yes.
Yes. So that's the burst out of it. So the sun is like the black part, and then that cloud at the top is the burst. So my questions will be on all this knowledge that Dr. Apollo has given. So first question is, we spoke about the possibility of metastasis. Which are the organs that give you tumors that often go and metastasize at the level of the brain? So cite, give at least 5 of them, anybody. And then the other question would be, can you describe the anatomy of the sphenoid and then its regional correlations? What is it in contact with? Because we said sphenoid ring. What do we understand by that?
I think the major distributors for METs are like bone, breast, lung tissue, colon cancer. I think sometimes choriocarcinoma can do it too. Yeah, those are the ones that I can think of off the top of my head. And then with the sphenoid, I would just think maybe because it has one of the major blood supplies like the MCA and the internal carotids and stuff like that. That could be.
Right. So for the METs, you cited some. You get definitely lung, definitely breast. You spoke about colon. That's good. How about the skin and then the kidneys?
Yes, those are the last two. Yeah, you're right. The renal and the skin.
And then the other question is, anybody else ready to tell us about, like, what is the structure of the sphenoid? Just describe it. What are the different major parts of the sphenoid? And then we can discuss the
Dr. Hillary,
anatomy.
can I add something
Yes,
on
yes, please.
MET before we move on? Yes. Organs which can, cancer which can spread to the brain, like you mentioned before, thyroid, breast, stomach, colon cancer, even from gynecology, like ovarian cancer. I even wrote one paper on ovarian cancer, which went to the brain. Prostate cancer, it can give you a subdural hematoma because it gives you extra-axial collection, like dura-based metastasis than intraparenchyma. Renal cell carcinoma, small lung cell cancer. So there are many things on the skin. You can get melanoma. Again, you can get choriocarcinoma, but there are tumors, there are metastases which can bleed into the mass. Those which bleed, you get renal cell carcinoma can bleed, melanoma can bleed, choriocarcinoma can bleed, and also thyroid can bleed within the tumor. Thank you.
Thank you so much, Dr. Kapil. Anybody up for the description of the sphenoid?
I have an image for the sphenoid bone in the next 2 slides.
Oh, awesome. Yeah. Okay, go ahead then.
Okay. So for you all, we have go for the diagnosis. It's the meningioma. Meningioma mean, or we can from the name even we can predict what it means. Meningio for meninges and oma for tumor. So it's like a tumor that arises from the meninges. As we have said, if we remove our hair, remove the skull, and then we remove the skull bone, we're going to face the 3 layers of meninges covering the brain: the dura mater, the arachnoid, and the pia mater. And as our doctor said, the pia mater is like an extension from the gray matter of the brain, so it's like so adherent to the brain. So meningioma is the tumor that arises from any of these 3 layers. It may as we have said in our CTs and imaging, that it can compress the brain, so the brain parenchyma or the nerves or the vessels. But most meningiomas are growing very slowly. Like our case, it's often asymptomatic without symptoms, only a headache, and like our case, it presented after 6 years of headache. So it's growing very slowly without symptoms, and most of the time it goes without notice. So meningioma have nothing significant other than it's like squeezing the parenchyma. It most commonly occur in women and discovered at old age, as we have said, like it have a very slow progression. In the past, 5% only from all the autopsies. Like in the past, we are going to do like a CT or an imaging and then find a mass. We don't know what our first step was to resection of this mass, going into doing a an open like a new surgery, a neurosurgery or a skull surgery, and then we resect the mass from the brain. So in the past, 5% only from all the autopsies reveal meningioma. The other was unknown until recently. And this is some numbers in 1970, only 2 out of 100,000 people we can go for a meningioma diagnosis, and it's like total incidence of 7.7, or like in 8 persons per 100,000 person. Excuse me. Okay. So with the modern, like in imaging, the discovery of meningioma has been trebled, and we are now easily can figure out what meningioma. And like I'm going to talk about the risk factors of meningioma. Actually, the definitive cause for meningioma is unknown, but some paper proposed that there might be a genetic background for meningioma. And 50% of the meningiomas have genetic mutation, which is in the neurofibromatosis 2 on chromosome 22, and other like have mutations in the TRAF7 mutation, and in 1/4 of the meningiomas. So the actual cause or the actual mechanism of causing the meningioma is not well known. And it have like some paper induced like a genetic background for meningioma. So we're going to talk about the pathophysiology and the classification of meningioma. The pathophysiology or the classification go for the WHO proposed a classification of 3 grades for meningioma. Grade 1, which was the typical one with no histological difference from the parenchyma, from the meninges histological appearance. On the other side, we have grade 2 and grade 3. Grade 2 showing clear cell meningioma, showing clear cell meningioma or choroid meningioma. And grade 3 is the papillary meningioma or the rhabdoid meningioma. Grade 2 and 3 are very rare, and they're accounting for like less 1% of all the meningiomas that occur. But on the other side, they are more aggressive and then have high risk of recurrence, and the prognosis is so bad. This is the way we classify or the WHO classify meningiomas is according to the histological grade and the extent of the tumor and the extent of the surgical resection we need to remove the tumor. So most of the meningiomas are extracranial, or have, like we have said, extraaxial or extradural meningioma or ectopic meningioma, all go for the same meaning. The place they are usually rise from the dura covering of the brain on the spinal cord. And so like we can think of, or like we can imagine, if we go out from the brain or the spinal cord, it will pressing on the pressing on the brain parenchyma will press on the head and neck region, and it's more specifically on the temporal bone. So on the other side, intracranial meningiomas, 98% of all meningiomas are intracranial, and most likely it will be in the parasagittal region, and less commonly it will be on the olfactory groove and the lateral ventricles. Like I have here the picture for the sphenoid. This is the sphenoid wing. This is the sphenoid wing. So this is the medial part of the sphenoid. This is the lateral part of the sphenoid. And then I have here ABC. So on this is the sphenoid wing, and this is is the anterior choroid process. We have sorry, where did the pointer here? Okay, this is the sphenoid wing, and this is like the pointing here is called the anterior clinoid process, and this is the okay. I have a problem with the pointer. This is the like tubercums celli, and they have here the anterior clinoid process, and this is the medial side of the sphenoid wing, and this is the lateral side of the sphenoid wing. So for our tumor, it was like in this region, so it was like coming out from the medial side of the sphenoid wing. So we call it sphenoid wing meningioma. So sphenoid wing meningiomas, like other meningiomas, are slow-growing tumor, which usually come out from the arachnoid matter, and the most commonly tumor, the most common intracranial meningioma, and they are most likely, like we have seen in our picture, to spread to the eye or the orbit, and affecting the optic nerve. So what are our management options? If anyone have input for what are our next step in the management of this meningioma?
Sorry, Ahmed.
Yes, I'm asking if anyone have like a propose for a management.
Okay. Before we talk about management, what did you say about where they come from, the meningiomas?
They come from like the meninges, the covering of the brain and the spinal cord, and they have extracranial and intracranial meningiomas.
Okay. Particularly which meninge? Because there are three: dura, meta, arachnoid, and pyramidal.
The dura and sphenoid is most likely to come from the arachnoid.
Yeah, meningioma comes from arachnoid, not dura, meta. Okay. From arachnoid cape cells. Okay, they used to think before that it was coming from dura, meta. Then they realized that it is coming from arachnoid cape cells, not dura. Thank you.
Okay. Thank you, Doc. If anyone have a proposal like for the management, what will be our next step for managing this case?
Thank you. I just want to add that also the management came from arachnoid cells, but also they have a strong attach from with dura mater. That help us sometimes to make easily the diagnosis between other tumors in imaging. Thank you.
Thank you. So if anyone have like what will be our next step in the management?
I can. So I think when it comes to managing this kind of tumor, some meningiomas are known to be very vascular, and like you said earlier, embolization is certainly one of the biggest options before you go into the operating room. Obviously, eventually this tumor would have to be taken out, and I feel like to decrease the vascular nature of the tumor, then embolization would be good. Also, because this tumor also is a little bit closer to the cellular region, consulting endocrinology wouldn't be a bad idea, just to get a good idea of where the patient's baselines are. I think this was talked about earlier too. So that's like one of the ways to go. So definitely endocrinology, and then go into doing embolization, and then go into the OR. So
that's great. So
okay.
Yeah.
I agree with you, Michael. Also, I think that depend of the location of meningioma, the management option could be changed a little bit. Now I have just a question for you, Ahmed. Let us know which type of meningioma you want. We discuss about the management. Convexity, I don't know, anterior fossa meningioma.
Our case, like the sphenoid wing meningioma. This
okay.
our case.
About spinal. Okay, great.
Okay.
I'm sorry to join you late because I traveled to this night or this morning, so it was a little bit difficult to me to attend the webinar. I'm sorry about that. Okay, about the sphenoidal wing meningioma, if I understand well.
Yes.
Okay, great. Okay. What you will give first for your patient, like information about his meningioma, the prognosis about your management. What do you do? Because before to manage this case, it is mandatory to talk with your patient first to explain him before to do anything. I don't know if you agree with me.
Can you please repeat your last sentence?
Okay. Sorry, I say before you will treat your patient. It is mandatory to discuss with your patient about the prognosis and about what you will propose for your patient, like management, what will be the benefits and the risk, because in this area, you have a lot of how can I say that you have a lot of structure.
Vital structure.
So what you think that you should tell your patient before to go, because we know that we should go to do excision about this meningioma. What will be your what is your how can I say that, what you are looking for? Do you think you can remove completely or not? Or what is the extension about this meningioma, and what was the clinical sign first before surgery, and what you will have like goals that you want to achieve after your management in this patient.
Okay, first I will, for the patient, of course, I will like telling him or propose the idea of he has a tumor in his brain, but the tumor is manageable and resectable, so we shouldn't worry about it. And like what I've said, like in most of the meningiomas are asymptomatic, so it may I can propose him that it's asymptomatic, and even if he from like the shock if he has a tumor in his brain, so I'll propose him that the tumors are usually asymptomatic and it are all manageable. If it may answer your question, doctor.
Hello.
Yes. Hello.
Okay, yeah, go ahead, Hugo.
Yeah, Dr. Hugo over here. I just want to get something a little bit clear. I don't know. I think this session way of doing is what I've been told is that the person that is presenting is the one that come up with some questions, and if we that are listening and following, we have some idea to help him build up his presentation very, very well. So we bring our expertise to help him to make the work easier. But now I don't know. Dr. Nodin, you are asking the presentation some questions. I don't know if it goes the other way. Dr. Ahmed.
Yes, I'm with you.
Does it go the other way out?
I don't understand your point.
Yeah, I was saying you are the one presenting.
Yes.
Yeah.
Yeah. I think I understand what you're saying. I understand what you're saying about the question. I think the questions are not supposed to be directed to Ahmed. Perhaps the
exactly.
It's to everybody else. Otherwise, Ahmed is under pressure. So everybody else should be answering.
Just getting back to what Dr. Nuru.
Yeah. Yeah, so going back to what Dr. Nuru was talking about, I think it's important to ask that question to everybody else, because if you're going to go to surgery with someone, you need to know what the goals of care are. You never go with the patient without having a plan. What are you going to do? And you need to warn the patient about complications. So let's not make, I agree with Dr. Hugh that this is not just Ahmed presenting. So everybody else think. So just to orient you, remember when we saw the lesion, Dr. Kabulo said this, look at that lesion. It is in contact with the cavernous sinus, and it equally has a relationship with the internal carotid artery. So the question Dr. Nuru asked is very valid. If you're going with a patient to the OR with a tumor like the one that we saw, that is vascular, that has a relationship with the cavernous sinus, that has a relationship with the internal carotid artery, what conversation should you have with your patient? Everybody else, please try and discuss, and then we can all learn from it, not just Ahmed.
Thank you for clarifying the question. I feel like going into this particular conversation with the patient, because of the proximity of the tumor to all of the important structures around that area of the brain, the skull, you should honestly have a discussion with the patient that you might not be able to get a complete total resection of the tumor. I think like one of the ways that we usually do this, especially with meningiomas, is using the Simpson's grading scale, which can help you to determine how much of the tumor you're going to be able to take out. So I think that's a place to start, that you might not be able to get a complete resection of the tumor, that you might have to leave some behind because of the proximity.
Thank you so much, Michael. Dr. Kabulo or Dr. Nuru, if you have anything to add to this, please
Okay.
You're welcome to add.
Thank you so much, Dr. Eric. I thought we are following Ahmed, what he's saying. Since he's the one presenting, it means he read something about that. Because why are we rushing to surgery? Is there something else we can do for that tumor before surgery? And always when we are talking surgery, it's the last option. Is there something else someone else can answer, not only Ahmed? Is there something else you can do for that before we reach the surgery? I think we have to discuss surgery at the end. And what do we do? How do we prepare the patient? And is there something else we can do apart from surgery?
Are you talking about the possibility of sort of radio surgery and chemotherapy, or is that what we're leaning?
I'm just talking about other thing we can do, because usually when we're talking about treatment, there's medical treatment, okay? There is maybe conservative management. It's also a way of managing the patient. When do we do conservative management? When do we do that option? Before we reach to surgery.
Gideon, go ahead and talk about, yeah.
Sorry, but I just thought, wouldn't we need a biopsy first to confirm that it's a meningioma in the first place to get a definitive diagnosis? Or are we saying that we could just sort of go with neoadjuvant chemotherapy and radiosurgery beforehand? I thought you would need a biopsy to have definitive confirmation.
Okay, so my question was, let me try to explain a little bit. It's like you get that tumor as sphenoid wing meningioma, which is like 2 centimeters in diameter, in a 90-year-old patient. Are you going to operate that patient? You see? And if it's an incidental finding tumor, are you going to operate that patient? You have to follow up. How are you going to follow up the patient? Maybe with serial imaging, until you see that this is now causing a neurological deficit, then you go for it. If you just, you get an incidentaloma, like they call it, you see the size of the brain, the brain tumor, and you don't operate first. You follow up. If the tumor is now growing in size, you can go in. If there are now neurological deficit attributable to that tumor, you can now go in for surgery. So conservative management is also an option there. Then apart from that, there are people who are just doing embolization for treatment of that tumor. It can be a very small tumor, you embolize it, then it will shrink. then you wait, or you can do radiosurgery. If the tumor is very small, not for the big one, you do radiosurgery, and then you can go for surgery. Now, we can now talk about surgery. When are we going to operate? What are the indications for surgery in that particular tumor? When do you operate? And how do you prepare your patient, and how you are going now to approach for that tumor? Thank you.
Yeah, thank you, Dr. Kabulo. So let's do this. Ahmed, please go back to the imaging of this tumor. And remind us the age and sex of the patient as well as presentation. Let's make a decision based on this case, and let's justify that decision. Thank you.
Yeah, thank you very much. That's what I want to say to Ahmed also. Thank you. Please, can you show us a brief summary of your case, please?
Okay. Our case
You
is
can go
like,
to the first image where you are talking about the case before you reach the image.
Okay, I can say our case is like a 40-year-old healthy female presented with 6 years of forcing headaches, 2 years of memory problems, and like a 2-minute episode of sudden onset of weakness of both legs without loss of conscious. And its prior medical history is like unremarkable or healthy. On examination, she is alert, have intact speech, have like cranial nerves and visual fields are intact, and only a mildness in the left arm and left leg. And her gait is balanced, and a mild left pronotor drift. And we did like a CT and the MRI, and the images are up there.
Okay, thank you very much, Ahmed. So we have here, this tumor is large. It is a large tumor, it is big tumor. We have a mass effect, and we have clearly the attach of dura mater that make us clearly that we are in a case of meningioma. And also we have some little bit classification intratumoral. So classically, that is the Sonoy wing meningioma. Okay. So in this case, like Dr. Kabulo said, also I think we have also some edema. I don't know if you have MRI imaging, please, Ahmed.
Those are all the images for the case.
Another sequence of MRI. No, or it's just these 3 images you have.
Just these 3 images. This is from the case.
And
this
the
is the
edema
neurosurgery cases.
Okay. So yeah, so we have edema. We have edema around the tumor. So okay, great. Okay, so like Dr. Kabulo said, we should go first to medical treatment to try to prepare the patient to the surgery, because in this case, you might not let this case for just embolization or radiosurgery. No, if not, your patient will come completely lost the vision. Could be might be died if nothing else done. So yeah, we should go to medical treatment. So what is what you will do like medical treatment to prepare your patient in this case? Yeah, you should use painkiller for headache. You should prevent vomit. You should prevent any factor that can raise the intracranial pressure of your patient. So I mean that you should give your patient corticoid, laxative, and painkiller. Okay, and it is mandatory to make before surgery how can I say that? Ophthalmologic exam complete. That means visual shunt, anyway, you should have before surgery a complete exam with ophthalmologist. Okay, and then you should prepare your patient for surgery. In this case, you can see that our tumor have extension to the sinus cavernous. but and you know well.
Dr. Nuru, I will have to stop. I will have to stop you there, because
okay.
it's becoming a presentation. Let's keep this for the students' opportunity to learn. So Ahmed, go now to your slide about management, and let's keep going.
Okay.
Let's have Ahmed continue.
Okay.
Okay.
Like our doctors thankfully said, surgery is like the last weapon I have to reach or use in our career as a neurosurgery. So like the management option, I would go for, like, first I will do a serious imaging, like Dr. Kapol said, as to see what is the goal of serious imaging, to see like the extent of the enlargement of the tumor. So if it's like slowly growing or like fastly growing, we know like in most meningiomas are slowly growing, but using the CT or MRIs will not clarify. One CT or MRI will not clarify its extent of growing. So first I would go for serious imaging, and like after that, like our doctor said, like go for the medical management. I go for corticosteroids, laxative for the edema. We have just saw on the CT, and to reduce also the pressure, intracranial pressure the edema is causing. And like our doctor said also, as I've said everything, we can go according to the extent of enlargement of the tumor and the extent of and its size. We can go either to radiation. If it's like a small tumor, we can go for radiation. Stereotactic radiosurgery using external beam radiation. It can be useful in small meningiomas. And on the other side, we have like embolization. We can use it for large sphenoid wing meningiomas, or large meningiomas. We can use embolization, and specifically, like we said, like meningiomas are getting their blood supply from either the internal carotid or the middle meningeal artery. So this will be target for our the branches of them will be target of our. And lastly, we go for the surgery. But our surgery will go for like a microsurgery, not actually a big surgery. So our surgery would go for like these two options we have, like the frontotemporal craniotomy, and frontotemporal craniotomy is centered. Will be centered to the the temporal bone. We are entering from the temporal bone, as we said, like the sphenoid ridge. The most sphenoid ridge is compressing here, or it is compressed here by the meningioma. So it will be our approach from this side, and if the tumor extending as we saw in our imaging, and if extending to the orbit, we're going to like doing an orbital osteotomy to reduce the brain retraction. And the other approach we have is the Dolenkin approach. It's for the lesions extending into the cavernous sinus, like Dr. Kapol showed us previously. The cavernous sinus are there, and the small dot are there. And so we're doing an MRI and see if it's extending to the cavernous sinus. We're going to have to do to do the Dolenkin approach, and this is for our management. And so surgery here, like we everyone see, the last approach I have. That's not the first thing I think of when I see such masses or tumor in the brain. So next I would go for the surgical technique. So
sorry, one moment, Ahmed.
Yes.
Anyone in the panel can explain why they don't do embolization of the arteries or the vessels coming from internal carotid artery?
Yeah, okay. I think it's better for young colleagues to answer. Thank you,
Yes,
everyone.
yes. You're welcome.
If nobody answers, we're going to call names.
Why they don't. Hello.
Sorry.
Is someone
It's possible
saying?
that you don't want to embolize because because it's too proximal to embolize, and there's a lot of branches of the ICA. So,
Not really. Remember, this tumor is dual blood supply. It gets blood from middle meningeal artery. It also gets blood from vessels coming from ICA, internal carotid artery. But usually when you embolize the vessels from the middle meningeal artery, not the branches from ICA. What's the reason? Gideon wanted to answer?
Sorry, I thought I understood the question, but now I'm a bit confused. Did you say, why do you not embolize the ICA or the middle meningeal branch? So I'm confused by the question. Hello?
I didn't hear you very well. I don't know if anyone heard
Yes.
Gideon.
Yes. So what Gideon is saying, he says he's a bit. He thought he understood the question, but he's a bit confused about the question. Dr. Kabulo just said this, right? We looked at that tumor. I think the issue perhaps is that we're not on the same page. When you look at that tumor, okay, everyone, think about the vessels that are at the level of that tumor. Dr. Kabulo said it really well. We have the middle meningeal artery. We have branches of the ICA. I think it's very important, first of all, that each of you ask yourself, do you remember the vascularization at the level of the brain? Because if you don't, then it becomes difficult. So ask yourself, where does the middle meningeal artery come from? What does it do exactly? And then think about the ICA. And then ask yourself, you're going to embolize this tumor. Where should you do it? Why should you do it? How should you do it? Just think about anatomy first. Start there. If you don't understand the anatomy, then it's difficult. So let's do anybody. Where does the middle meningeal artery come from?
it's a continuation of the ICA.
Middle meningeal.
Oh, middle meningeal. Oh, it's it's from the internal maxillary artery, rather.
And the internal maxillary is a branch of?
The external carotid.
Okay.
Yes, thank
Please,
you.
Dr. Kabulo, go ahead.
Yes, here you don't embolize vessels coming from ICA. There is a risk of having stroke. You might miss that vessel, you embolize another one, which is not going to the tumor. Then you get stroke. And also there is a risk of tumor now bleeding into, there is a risk of bleeding into the tumor. But the major complication for embolizing a vessel coming from ICA, it's a stroke. You might get a stroke while embolizing another artery going to the normal brain. That's why they don't recommend to embolize them. Thank you.
Okay, can I say, okay, thank you, Kabulo. You should get in mind that the goals of your surgery, it is to do your best to your patient, to don't lose your patient on operate room. So you should go to embolize the tumor, intratumoral embolization. It is different to embolize, to try to embolize the pattern artery. No. Like Dr. Kabulo said, if you go to embolize pattern artery, you may get some risk like a stroke, because you can have a high risk to obliterate the perforant branch who come from this pattern artery. So no, just do the embolization intratumoral. That will help you to have less bleeding per procedure. That is the goal of embolization. Thank you.
Thank you. Juanita has a question.
When do you perform now surgery after embolization?
You mean, Dr. Kabulo?
Yes, in your practice, when you get, you embolize a meningioma, after how many days will you now proceed to the surgery?
In the 24 hours after embolization, you should go to your surgery. If not, you may lose the benefit of your embolization.
Okay. I was somewhere where we're doing 7 to 10 days after embolization. because it will help you. You get necrosis of the tumor, and it's now easy to debulk.
Yeah, you agree, but I think that you can about
No,
1
can
week
I something?
you can about hemangioblastima with high risk high risk of you should wait. But yeah, I am agree with you.
I have to
Hello.
I have to stop this high level conversation though.
Okay,
Because,
okay,
remember that
okay.
we have medical students. I think that the important thing here is for them to understand what Dr. Kabulo just said, right? For the medical students, think about the carotid artery. You have a common carotid artery. You have an external and you have an internal. Where does the external carotid artery irrigate? Where does it go generally? Anybody answer. It's not a trick question.
Is this mostly outside of the skull, which is usually the facial elements?
Okay, very good. That's the first thing that you need to keep in mind. The next thing is what does the internal carotid artery irrigate mostly? Anybody?
I guess it's one of the more important vessels that goes directly into the brain.
Yes, so the anterior circulation.
Yeah.
So there's that risk. This is how you need to think about it. Think about how the vascularization is at the level of the brain. You know your circle of Willis for everybody. So if you go into the internal carotid artery, there's always that risk that you might end up stopping the blood supply to a portion of the brain. If you do that, that is a stroke. That's the definition of a stroke, literally, right? And if, on the other hand, you are going through the external carotid artery, you have a lesser risk than that of the stroke. This is what Dr. Kapulo is talking about. And that's why you need to go back to your neuroanatomy. So if you find it difficult to follow, then it might be that you need to reread your neuroanatomy. Joanito had a question. Go ahead.
Hello. Yes, I wanted to ask a question. Someone hinted about a biopsy. I wanted to ask, with the kind of, if you have like the stereo imaging and you kind of visualize the tumor, how necessary is a biopsy in terms of our management? Thank you.
Yes, so the question is how necessary is the biopsy in terms of management? So it's first things first. When Ahmed was presenting, he spoke about the classification of meningiomas for the WHO, right? And if you go back to the different types of classifications for the WHO, with the most recent being 2016, if you just go and read that, what you find is you definitely need to have a tumor sample with some biomolecular workup to be able to classify. And apparently there will be another classification this year in 2021 that'll be coming out very soon. So already for that's very important because it helps with information management and tracking. Otherwise, it's difficult for people to compare because you don't know if you're comparing apples and oranges, right?
Okay, can I add something?
Great.
Yes.
So, yes, Joanita, biopsy in neurosurgery, it helps to name the tumor. You have to know the tumor you are dealing with. But for meningioma, it's very, very, very rare to do a biopsy because it's the only tumor you can diagnose from imaging in neurosurgery. So from imaging already you know that this is a meningioma. So it's very rare to do a biopsy in meningioma. Like in this particular case, you know already those characteristics on imaging, and you don't need to go for a biopsy. But in general, biopsy, like Dr. Ilrik saying, it will help you to know the grade of the tumor and so on. But rare in meningioma. Thank you.
Awesome. Ahmed, can you go ahead?
Yes. Okay. So we're going to talk about the surgery itself. So next will be the surgical technique itself. For our surgery, the tumor, like we have seen, is coming out from the sphenoidal wing And our approach would be the patient would be positioned like in picture A, positioned in supine position with the head turned like 45 degrees to align the sphenoid ridge vertically along the floor to the floor. And like we can use, like we have said, like a corticosteroids or laxative or like a mannitol to reduce the edema, intracranial edema, to reduce the pressure. And then I'll go using a stereotactic MRI guided navigation to see how it will go. And also I can use an intraoperative neuro monitoring, monitoring the cranial nerves in case of cavernous sinus invading lesions. So picture A is the position, illustrating the position we're going to place our patient, and then I would do then we're going to do like a cold incision called curvilinear incision around the temporal area of the patient, temporal hairline. It will allow us the exposure of the temporal area and allow it like a direct entry to our tumor. Like in the standard frontotemporal cranectomy is completed using like doing a holes in the points here you see in the 1, 2, and 3. The point 1 is there in the temporal bone, point 2 in infratemporal bone, and point 3 is like a posterior of the frontal bone. And then our next step will be the drill. We are going to use the drill to open the skull at these likely points we have just said. And then afterwards, we're going like the sphenoid ridge is then drilled, and then we're going to apply like a bone wax during the drilling of the sphenoid bone to limit the blood loss. And afterwards, like picture C, we when we open the skull, we're going to fade the dura matter, and then the dura is opened in like a C-shaped fashion, and we can like flap the anterior and the inferior and the lateral sides, like we see in picture C. After then, we're going to operate using a microscope. Using a microscope, we're going to dissect. The dissected tumor will start at the anterior sylvian fissure. Anterior sylvian fissure is there directly and like near the sphenoid wing, and it contains medially to release the cerebrospinal fluid from the arachnoid cisternae. So for those, I guess I have like an image for the brain there, illustrating the way we are doing our surgery. And then upon we're going to reach the tumor base. So upon reaching the tumor base, the tumor is disconnected or slightly cauterized using cauterizes from the dural blood supply by dissecting it along the sphenoidal ridge, and then to prevent the revascularization of the tumor, or to prevent the recurrence of the tumor. And then specifically for sphenoid wing meningiomas, we can like they can vary from the texture itself, from soft to fibrous tumor so the tools that is useful for debulking, including bipolar and suction for the soft lesions. And like we can use the electrocautery, as I said, for devascularization of the tumor. And then using, like I said in the first, the navigation or the stereotactic navigation to identify the cranial nerves, the blood vessels. Like we have to take in consideration, like in like our tumor that is so near to the optic nerve. So using stereotactic navigation is very useful. So we can now we will not going to injure the optic nerve that will cause our patient to be blind. And when operating on large tumors, we debulk or dissect the tumor all through along the tumor capsule outer surface. So we dissect the tumor all through the tumor itself, but all around the tumor, trying to keep the arachnoid matter intact, and dissecting up or out the tumor without injury, without causing injury to the internal carotid, like Dr. Kapul said. So to prevent the incidence of stroke. And we don't want also to injure the other vital arteries, the middle cerebral artery or the anterior cerebral arteries, like the anterior circulation of the circle of Willis. And that is all about the surgery, how the surgery would go. So if anyone propose a complication for our case or our surgery, would anyone have a thought of complication for the surgery?
I have a couple. I mean, definitely because of the close proximity to the vasculature, definitely nicking the blood vessel is a complication. Also, even nicking the optic nerve is also a complication, or other cranial nerves that are around that area.
Yes, and that is the why we use the stereotactic navigation to see how proximal we are to the arteries and how proximal we are to the cranial nerves. Great, thank you, doctor. And if anyone have other complication, just Dr. Kapul just have just told us one about the. Anyone have anything to propose?
There's always a risk of infection, and I'm guessing because you're so close to the cellular region, there may be sort of hormonal sort of fluctuations as well. You may get that.
Yeah, I agree.
But one question I do have for anyone is, why wouldn't you sort of do an endonasal approach, or a transsphenoidal through the nose? Why isn't that a suggestion in terms of approach? Is that just is it not situated in the right place?
I don't hear you well, please. Can you repeat your question?
The question is, why don't we use through our transnasal approach for our tumor? Our tumor is like a sphenoidal wing, so it's easy to reach through transnasal approach. Why don't we use it?
Yeah.
Okay. You know, it is simple. I know that some team in USA and Japan sometimes use this approach, but it is not common use because it is difficult to reach gross total excision with less complication. It's not easy. It is better to use like Ahmed say pteronal approach or frontotemporal large approach in this case. Yeah, because it is sphenoid wing. It's not. No, this situation no. And also, I think that what you say it is a good point, because also we should also type our meningioma if it is lateral, medial, what is the invasion. In some case, yeah, you can think about endoscopy nasal. But me, I just want, I like you said, a complication. I just want to know, because my question is still not answered, because you will go to operate case like that, Ahmed.
Yes.
You should tell your patient what is the first risk that you can have, because if your patient don't have any visual, because in this case, you may have sometimes oculomotor palsy after surgery. I will send in the chat one of paper recently published in spinal wing surgery. That's what I was talking about, because this surgery, it is not simple surgery. It is very high risk surgery. You should have that in your mind. You should do your best, so don't give a lot of worseness of your patient. So, like you ask people now, I want to know, please let us know, what do you think?
Neuro, I think you should give it directly instead of asking. Yeah.
Okay, great.
Before we go to Nuru's questions, can I add something on Gideon's question?
Yeah, go ahead.
I wanted something to.
Gideon asked about transnasal
approach.
Yes.
He said endonasal.
Endonasal or transphenoidal. Okay.
It's the same.
You want access that tumor. It's far from the cellular region. Of course,
exactly.
It is already invading the cavernous sinus, but it's not reaching the cellular region. If you go there, you won't reach it. You have to cross the cavernous sinus before you reach that tumor. You damage more. So there's no indication for this particular tumor in only when it is invading, it is going up to the cellular region, then you can use that. But sometimes they do, even if it is reaching there, you can do combined approach, endonasal and, for example, Dolenk approach. Why are they using Dolenk approach? Because Dolenk approach will allow you to reach even the cavernous sinus and remove part of the tumor which is in the cavernous sinus. So in this particular tumor, there is no indication for endonasal transphenoidal because the tumor is not reaching the cellular region. Thank you.
And I can, I guess, like the tumor size also, to prevent us from doing the transnasal if the tumor size is so like big.
Of course, even if the tumor was arising from cellular region, if it is lateral spread, you won't do endonasal approach because you want to reach the tumor which is far from there.
Yes.
Yeah, so what I was meaning is this. So you should try to explain your patient that you may have a hemorrhagic complication after your surgery. So you should need to come back to operate your patient. You should explain to your patient you may have also epidural hematoma or acute subdural hematoma. You may have also infection like I think Gideon say before. You should explain all those complications to your patient before to go to surgery. And also you may have an intravascular injury, intraoperative vascular injury also. You can have that perioperative. So you should explain that for your patient. And also you may have oculomotor palsy. And this oculomotor palsy, sometimes you may avoid that if you have intraoperative neuromonitoring to try to prevent this oculomotor palsy. But you know, well, in our context in Africa, it's not all centers who have that. So you may explain your patient because you may get risk like 1% to 3% to get in oculomotor palsy, and a lot of patients don't like that aesthetically, and they don't like. So you may explain to the patient that also. And you may also, how can I say that? You may also worsen the vision of your patient. That's why it is mandatory before surgery to have a complete checking with ophthalmology. And you may explain also your patient that you may not remove all the tumor, because some patients think that, yeah, I will go to do surgery for my tumor. So they in their mind, when they will wake up, nothing will rest. So you should remove everything. But you may explain to your patient that no, will not be easy for you to remove everything. The gross removal occur maybe 40 and 87 or 90% of removal of tumor in this location. It's not a convexity. So it is, you may explain to your patient, yeah, maybe I may less some residual tumor and let that for radiotherapy or radiosurgery after, because it will not be possible to remove all that. So you should try to explain the goals and the complication to your patient, and then you will take together the decision to operate. Thank you.
Okay, thank you, doctor. So, like our doctor said, like the complication would be about, like summing up, the complication would be about intraoperative bleeding. That can be one of our complications, especially those large tumor with the large tumor invading the anterior blood supply for the anterior the anterior arterial supply for the circumflex, and like so to prevent this intraoperative bleeding, like we said before, doing an embolization is much recommended. Also, we have like stroke and vascular injuries, injury to the internal carotid artery, to the middle meningeal, to middle cerebral artery is proposed as a complication. So, like doing an computer assisted navigation, it helps you avoid these vascular injuries. And we can use also a micro Doppler, and that's for preventing stroke and vessel injury. Our third complication can go for cranial nerve palsies. So especially like our case, the middle spinal wing meningioma, it can cause injury for like the cranial optic nerve and the three other nerves innervating the eye, the abducent and the oculomotor nerve, and this can occur during the resections. We can injure these cranial nerves, and so to use this to prevent this, we can use an intraoperative neurophysiological cranial nerve monitoring. Like our doctor said, it may not be available in all institutions in Africa. But we can use it as the neurophysiological cranial nerve monitoring. And so also we have like an optic nerve, it can be injured as well. So avoid injuring the optic nerve will easily be done by decreasing the intracranial pressure by using, like we have said before, debulking the tumor using like corticosteroids or like laxative to decrease intracranial pressure and the edema, so we can easily see the optic nerve and prevent its injury. So this goes for our complications, and that's it for our session for today. And if anyone have another questions, please tell us if anyone have another question to ask.
Ahmed, are you done with the presentation?
Yes.
Oh wow, fantastic! Congratulations, you did a great job, man.
Thank you.
Honestly, this is really well done. Really well done. Thank you so much.
I'm agree with you. I'm agree with you, Ulrich. I'm so surprised the way that he made the presentation. Beautiful and well done, Ahmed. Beautiful.
Thank you for the words. Thank you, everyone.
And a special thank you to Gideon and Michael for contributing. I really hope the others will be will try to answer the questions next time. We're doing this so that everyone can learn. So feel free to answer if you're not sure about something and ask questions. We want more interactions for next time. Thank you to the two I just mentioned, because they did a really good job contributing. That's the best way to learn. And Ahmed, bravo, man. Good job.
Thank you. And this is my email in the first of the presentation. If anyone want to see like another resources to be more like to gain more information about the meningioma, feel free to just email me and I will send you like a ton of resources. Thank you everyone for attending today.
Yeah.
And sorry if I was like an anxiety.
No. You shouldn't be sorry for anything. Chibukem says he has a question. Go ahead, Chibukem. Ask a question.
Yeah, thank you very much, Ahmed, for your presentation. Brilliant stuff. Yeah, I just wanted to ask, what are the like anyone can answer, and then I'll see it as well. What are the current hot topics as regards sphenoid wing meningioma? Hot topics could be new treatments plans or possible research topics. I don't know. Thank you.
Oh, please, I don't hear well your question. Sorry.
Okay, yeah.
His question is, yeah, go ahead.
Yeah, I was asking what are if there are any current hot topics on sphenoid wing meningioma and possible research questions that could be answered.
So Chibukem, I recommend that you read the article Dr. Nuhu has just shared in the AFAN group. He shared a good article about sphenoid wing meningiomas. I think if you read that article, you'll get a good idea of what level the literature is at right now. And just because that is more of just because this is more of like a research question, I really want to make this focused around clinical, because the demand has been around doing more clinical stuff.
Okay.
Yeah, I am very, very, yeah, thank you.
Okay, Ahmed, congratulations. That was fantastic.
Thank you.
I'm impressed. I'm impressed with that level. Even me, when I was a medical student, I wasn't intelligent like you. That was fantastic. Keep it high. Continue reading. In my country, we say when someone is shining, we say you are a star. So continue like that.
Okay, and for Lawson, I will send the PDF version of the presentation, and someone is asking for the presentation. I will send it, or just like email me, and I will send you all the presentation and the resources.
I forgot to thank our seniors for being here, Dr. Kabulo, Dr. Nuru, Dr. Hugh. It's always good to have you. You're so supportive, honestly.
Yes.
It is so great to have you guys, and we hope that you keep doing it. We know you will keep doing it. And thank you, Darwin, for putting this together. And again, Ahmed, you killed it, man. Stop apologizing.
Thank you.
You killed
thank
it.
you. And sure, thank you for our mentors and doctors.
No, guys, I was sleeping and I was dreaming about the presentation, and I wake up because I was so tired because I come from travel. I come to see my family. So I come in this morning, 4 a.m. and I was sleeping. I was dreaming about. I said, "Oh, great! It is the time of."